Good afternoon and welcome to the finale of the 2013 African American HIV University Symposium. My name is Ken Lazarus. I'm here representing the wonderful city of Atlanta, Georgia. It's been my privilege to share in this wonderful journey and experience as a 2013 fellow. Well, I start briefly with a historical sketch of Atlanta. Atlanta is the capital of and the most populous city in the U.S. state of Georgia, with an estimated 2011 population of 432,427. Atlanta's first official name was Marthasville in 1843. It was known as a terminus for rail support throughout the Southeast. It later became known as the town of Atlanta in 1845. And finally, the city was organized as the City of Atlanta on December 27, 1847. The Atlanta metropolitan area, and unofficially known as Metro Atlanta, is the most populous metro area in the state of Georgia and the 9th largest metropolitan statistical area in the United States. It's the core of the broader combined statistical area. Atlanta, as the capital of Georgia and the state's largest city, is its economic, cultural, and demographic center. The Atlanta combined statistical area spans up to 39 counties in North Georgia and had an estimated population of nearly 6.1 million people of the total 9.9 million Georgians who reside in the 159 counties of the state, with Georgia ranking second only to Texas in the number of counties within a state. It is the second largest metropolitan region in the Southeast, thus the nickname, the Mecca of the South, with specific reference to its African American influence and population. So as we look at our community epidemiological HIV profile, Georgia was ranked 6th highest in the nation for the total number of adults and adolescents living with HIV infection in 2010. As of 2012, December 31st, the total number of persons living with HIV infection in Georgia was 50,436. This represents an increase in HIV prevalence of 53% from 2005. Of these, 45% had HIV, not AIDS, and 55% had stage 3 disease or AIDS. So here we share our estimated persons living with HIV infection in Georgia and metro region as of December 31st, 2012. We have our Black, non-Hispanic Georgia, 32,320, and Metro Region, 19,569. As you can see across the board, Metro Atlanta represents the largest percentage of these cases. Among the 18 health public districts of Georgia, Fulton and DeKalb counties, where Atlanta resides, had the highest numbers and rates of persons living with HIV infection and stage 3 AIDS through 2012. Almost 2/3, or 64% of persons living with HIV infection in 2012 resided in the Atlanta metropolitan statistical area. So according to James Curran, who is our Dean of the Public Health of the Rollins School of Public Health at Emory University, surveillance is the conscience of the epidemic. So I just wanted to share a little bit about our surveillance mechanisms in Georgia. We begin here with our healthcare providers and our paper-based case reporting. We go through all of our surveillance mechanisms, our methods, and our EHARs, our electronic health registry system. Finally, to our progress reports, our research, and then finally our monthly submission to CDC. And this is how we track all of our epidemiological data in Atlanta and the state of Georgia. So males living with HIV in the state of Georgia, we see here, not unlike other cities, 60% here is represented by African American, even though in the state of Georgia, there's only 28% African Americans. So consistent with the national trends, approximately 15% of all of the new HIV/AIDS diagnoses in Atlanta are among senior males, as per the transmission category. And that is going to be our focus area here with this particular presentation, HIV and aging, ready or not. So as we look at our males living with HIV by transmission category, again, we see that MSMs are 70%, IDU at 8%, MSM and IDU at 6%, heterosexual contact at 7%, and other at 9%. And we list our data sources here. This comes from adults that are greater than age 13 that are diagnosed by 12/31/2010, living as of 12/31/2011. And in Georgia, that amounted to 30,696. So again, 15% was consistent among the senior males. Here again, we looked at our females living with HIV by race and ethnicity as of 2011, and we had 75%, surprisingly not, African Americans, consistent with the trends that we see, even though there's only 31% of African American females in the Georgia census as of 12/31/2011. So our transmission categories, again, heterosexual females accounted for, heterosexual contact amongst females accounted for 70% of the transmission category with females. Here I just shared some of our geocoded data. These are cumulative cases of HIV infection. This area right here amounts to the city of Atlanta, and this is the heaviest portion of HIV cumulative cases. Next, as we move through here, this again is most of the city of Atlanta, and this is by current district of residence, and the darker area represents where we have the heaviest concentrations, and then this is new diagnoses. And still here on this portion of the city of Atlanta, we see that we have the highest incidence of new cases. So this just gives you a little information about our HIV continuum, care continuum methodology, and how we have done that. We begin with adolescents and adults age 13 or greater, diagnosed by 12/31/2011, as I said earlier, who have a current address within Georgia. And this is very important to our viral suppression rates that are linked to care, equal CD4 viral load within 3 months of diagnosis date. We define engaged as care as 1 CD4 viral load in 2012, retained in care as 2 CD4 viral load at least 3 months apart in 2012. And so this is important because one of the goals that we want to do is decrease the presence of HIV and AIDS and decrease the viral load in the community, but increase our viral suppression rates in the state of Georgia and Atlanta. So here again, we show our cascade. 84% linked to care, 59% engaged, 43% retained, 39% on ART, and 41% virally suppressed. There's a little bit of a discrepancy here, and we attribute that to the lack of adherence on this particular category of persons who are on ART. So viral suppression among those retained in care in Fulton County, this gives you the numbers. 73% African American of the total number, 79% were Hispanic of this total number, 88% white of this total number, and 84% others unknown. So when we looked at our trends, we felt that it was not good enough to just look at the overall numbers. We needed to look at our subgroups. And the subgroup that I've selected is seniors, 50 plus. And so we wanted to look at new HIV diagnoses among blacks overall that are decreasing. New HIV diagnoses are increasing among younger black males and older black females, which ties into our senior population. And our different groups need different interventions. So even the youngest age groups, at least 10% are late testers coming in at stage 3 AIDS at diagnosis or within 12 months. So as I looked at our summary of our needs assessment, these are some of the findings that shaped our proposal. We found that synergistic effect of aging and HIV creates an array of needs. Both physical and mental health were interconnected for most participants who struggle with comorbidities that impact their quality of life. We had inaccessibility of appropriate mental health and substance use programs creates barriers to housing as reported from our focus group. We had high levels of anxiety about future needs and care And I must say that as someone who's now in their 50s, who's been living with AIDS for more than 25 years, this was a very personal topic for me. And I could relate very carefully to the level of anxiety about future needs and care, because we never anticipated that we would have so many seniors living this long when we first encountered AIDS or GRID back in 1981. So also, complex health issues cause isolation for aging persons with HIV and AIDS. And our complex needs due to multiple health issues requires a nexus of health care, and those we will address in our recommendations a little bit later. So as we looked at our demographics, I just wanted to share that we had a total of 31 persons in our focus group. We had 4 heterosexual male, 4 gay, 6 who identified as bisexual, 14 MSM for 28 males. We didn't have that many females, but we had 1 heterosexual female, 1 who identified as gay, 1 bisexual, for a total of 3. Half were minimally engaged in HIV care with at least 1 CD4 viral load in a 12-month period. 37% were retained in care. 40% were virally suppressed. And among MSM, age 55 plus, viral suppression varied by race. 30% Hispanic Latinos, 39% blacks, and 45% whites. Among those age 55 or plus who were retained in care, viral suppression was 87% for males, 83% for females, 84% among black MSM, 91% among Hispanic, Latino MSMs, and 92% among whites who are MSM. So one of the conclusions that we drew was that persons living with HIV in Georgia, age 50 or plus more, were more likely to achieve viral suppression than younger age groups. But disparities by race will be synergistic with disparities in comorbid conditions such as diabetes, hypertension, and heart disease to impact longevity. Clinical and public health measures must address retention in HIV care, ARD adherence, tobacco cessation, and control of other medical conditions. So as we moved on, we looked at our Black Treatment Advocates Network. And this is at the core of the work that we have been doing. So everyone knows that the Black Treatment Advocates Network is the first collaboration of its kind that links Black Americans with HIV into care and treatment, strengthens local and national leadership, connects influential peers, raises HIV science and treatment literacy, which is important in Black communities, and advocates for policy change and research priorities. We know the mission is to produce and support a nationwide network of highly trained Black treatment advocates who will serve as educators and opinion leaders in their communities, provide a pipeline of trained Black Americans for community advisory boards, facilitate expanded Black participation in clinical trials, increase early utilization of appropriate treatment, and improve treatment adherence in Black communities. And the goal is to cultivate and support a national network of Black treatment advocates and educators equipped with knowledge and skills. So, the BTAN began in 2010 working in 3 cities, first in Houston, Texas, Jackson, Mississippi, and Philadelphia, Pennsylvania, my birthplace, hallelujah. In 2011, networks were expanded to 3 additional cities: Atlanta, Georgia, where I currently reside, Chicago, Illinois, and Los Angeles, California. In 2012, networks were expanded to 6 new cohorts: Baton Rouge, Louisiana, New Orleans, Louisiana, Oakland, California, San Francisco, California, Fort Lauderdale, Florida, and Miami, Florida. Then in 2013, additional networks were welcomed in Melbourne, Florida, Minneapolis, Minnesota, and Richmond, St. Petersburg, Virginia via the 2013 AAHU Fellows Program. So the training process, BTAN's intensive HIV science and advocacy trainings consist of 2 3-day sessions covering a wide range of HIV/AIDS topics, including testing resources, treatment strategies, linkage to care, and community mobilization, among others. The initiative began in 2010 and through 2013 has conducted trainings in 15 cities. The year 14 will see BTAN expand to additional cities. BTAN was launched as a partnership initially between the Black AIDS Institute and Merck. Our guiding principles, as I call them, BTAN is a part of a commitment by the Black AIDS Institute to help raise HIV science and literacy in Black communities. BTAN is guided by the premise that when people understand the science of HIV, they are less likely to participate in stigmatizing behavior, they're more likely to access treatment, they're better able to adhere to their regimens, and better positioned to influence HIV and AIDS policy. So these are the 4 core areas that we have been assigned to look at: treatment education, patient navigation, disclosure, and advocacy. Today, as one of my fellow cohorts has shared, we have looked at the logic model, our objectives, our activities, our outputs, our outcomes, and our impact. Because I hear better than I see, I had to make this a little bit larger. So we looked at some of our objectives: to serve as educators and opinion leaders. I won't go through all of this because we have gone through most of it. Our activities, and these are the 4 areas: advocacy, disclosure, patient navigation, and treatment education. Our outputs, we expect that we will have 200 treatment education sessions. Our outputs, our outcomes, and our impact after the initial planning are the most important for us. 1,000 Black persons living with HIV and AIDS linked, retained, or re-engaged in care. 50 BTAN members serving on HIV planning groups or councils, and this ties back to having influence for policy. 100 disclosure experiences with persons living with HIV and AIDS. And then our outcomes: to increase the science and treatment literacy of the Black HIV/AIDS workforce, to increase the number of Blacks who reach viral suppression, tying back to our goal, and then increase the number of Blacks serving in HIV/AIDS decision-making positions. And finally, our impact: increase in viral suppression among Blacks, persons living with HIV and AIDS, a decrease in viral load in the Black communities, and increased participation of Blacks in clinical trials. And Blacks, BTAN is in the following cities, and they should have been listed there, but I've already shared that with you. So as we look at advancing BTAN here in Atlanta, BTAN was launched in 2011. We had our first training on August 8th through the 10th, 2011. And our second was September 14th through the 16th in 2011. So we have an existing BTAN program. We have developed partnerships with Dr. Patrick O'Neill, who's the Director of Health Services for the Georgia Department of Public Health, who also serves as the Principal Investigator for the CAPAS, Care and Prevention in the U.S., and HIE, our Health Information Exchange Initiative. We are working closely with Dr. Jane Kelly, who's Director of Epidemiology Division for the Georgia Department of Public Health, Candace McCarty, Director of the Ryan White Part A program. Although Ms. McCarty has just recently retired, we have an interim at this particular point. We're also working with the Director of the Ryan White Part B program, William Lyons, and Veronica Hartwell, Director of the HIV/AIDS program for the jurisdiction of Fulton County. And I must note that in Atlanta we have a duplicitous situation because Atlanta is not only the capital seat, capital of the county, so we have the county, the city, and the state, and CDC all fending in the same jurisdiction. So that's why we have so many multiple partners going on at the same time. And here we have Dr. Patrice Harris, who's our Health District Director for Fulton County. So not only is it the capital of the Atlanta is the county seat, we also have it being the home of our health district. We have our Dr. Matthew McKenna, who has been working with us as our medical director, and our health promotion staff at Fulton County, Dr. Nazira Dawood, who was instrumental in helping me plan our science and treatment training. We're also working with Emory Hope Vaccine Clinic. I work with them with their CFAR, Dr. Paula Frew and Dr. Mark Mulligan, Dr. Carlos Del Rio, and Dr. Jeffrey Lennox, who are part of the Emory Center for AIDS Research. In addition to these public health officials, we've also forged relationships with the executive directors of AIDS Atlanta, which is our region's largest ASO, executive director of the Living Room, which provides the housing services through HOPWA, Dazon Dixon Diallo, who's the Executive Director of Sister Love, is our region's premier ASO providing HIV services to women of color, and it's also the local sponsoring agency of the BTAN Atlanta. Now, to round out this very aggressive meeting agenda, I decided to also meet with persons who are living with the virus, as well as board of directors of these various agencies, so that we could present our project to for a full vetting across an array of different cohorts. As we looked at engaging traditional Black institutions, we went to our local senior centers, our HBCUs. We're the home of Clark Atlanta, Morehouse, Spelman. We also have the Black Church and various denominations that we're working with, the Southern Leadership Christian Council Conference, the National Council of Negro Women, and the Center for Black Equity. So as we look at our BTAN meetings, we are hosting bi-monthly Lunch and Learn series. The Atlanta affiliate of BTAN will host quarterly membership meetings to conduct network business. So the primary focus of the quarterly meeting will include membership drives, advocacy training, and program planning for upcoming events. The membership is diverse, including members from the MSM, men who have sex with men, the transgender community, senior persons, veterans, and others at-risk populations. So we looked at our training. We did a one-day Science Academy training after our internship one, and we focused on origins of HIV. The presenters were Ken Lazarus and Dr. Dawood. We looked at some of our science training. We did this with healthcare professionals, and I was very interested to see how they would score. So our pre-test score, we only had 5% that scored 90% or better, 20% scored 80% or better, 10% scored 70% or better, and 65% scored below 70%. In the post-test, we had some increases to 30% that scored 90% or better, 10% scored 80% or better, 15% scored 70% or better, but we still had 45% who scored below 70%. So, as we know, we still have a lot of work to do, even with our healthcare professionals. And this is a photo from that particular training. Our 3-day BTAN science and treatment training is going to be held in the fall, and we will use that as a recruitment tool for our next. We will focus on treatment as prevention, biomedical behavioral interventions, and HIV health literacy. So when we move to our BTAN project plan, the aging of HIV population, ready or not. So the problem statement, 34% of people living with HIV and 41% of people living with AIDS in Georgia are age 50 and older. And it's been anticipated that by year 2015 that 50% of all persons living with HIV will be 50 years or older. And since the advent of highly active antiretroviral therapy in the mid-90s, deaths due to AIDS declined in our area by 53%, from 1,533 deaths in the year 1995 to 723 in 2000 to 277 deaths in 2012 in Georgia. Our aim in this analysis was to examine retention in HIV care, viral suppression, and the presence of comorbid conditions in age 50 and older HIV population in Georgia. So, the aging of persons with HIV and AIDS, I consider this a hidden epidemic. Infected people who have lived decades longer than anyone imagined are now being hit with a host of aging illnesses in their 30s, their 40s, and their 50s. They include dementia, cardiovascular and liver disease, cancers, diabetes, osteoporosis, emphysema, and kidney problems. So our primary objective is to identify issues of access, quality of care, and support and housing services for persons living with HIV and AIDS who are aging. Those with aging-related illnesses, complex care, cognition issues, and acute health issues. Our secondary objective was to identify issues and challenges that aging persons experience in their everyday life, and we did this through our focus groups. Develop an understanding of what care, treatment, and support services aging persons with HIV and AIDS are receiving and accessing identify the gaps in care and services, and explore how these gaps impact their lives, and identify strategies to address the gaps. We use quantitative and qualitative methodologies were used to collect data, and one primary focus group was conducted. So as we look at the four areas of concentration, I shuffled it a bit so that the acronym would now be DATE. D-A-T-E. It's focused on the senior population. So when we look at disclosure, we identified our target population as persons 50 years or older, with a minimum of 50 to a maximum of 100 persons to be served. And so given the increasing trend among senior Black females in our area, the topic of disclosure arose as a significant factor, as most females reported as being engaged in monogamous sexual relationships, which leads one to speculate that their partners did not disclose their status. So advocacy. We wanted to do advocacy 101 training, which will provide it with emphasis on the needs of the 50+ age demographic. Treatment and education will focus on the specific treatment needs of the 50+ age demographic related to the intersection of HIV disease and comorbid diseases that generally impact the elderly sector. Pre- and post-test processes will be utilized to strengthen the education level of the participants. And then patient navigation. A peer navigation model will be utilized to increase the effectiveness with which the participants can rotate through the medical and scientific processes of treatment and care. So, as we move to our successes and challenges, successes for me were, this was a great learning opportunity. And challenges was time management and availability of financial resources to support the total program elements. So I move quickly to our conclusion and recommendations. So where do we go from here? Sustainability. In terms of BTAM, we will work towards our membership and do leadership training and development. Resource development. We will like to work with the Black AIDS Institute to fund expansion of the network into the 5 high-impact areas of Georgia: Atlanta, Savannah, Columbus, Macon, and Augusta. We feel that this will strengthen the network's statewide presence. And these are the core areas that we plan to do, starting with Atlanta, BTAN, and moving to Augusta, Macon, Savannah, Columbus. This is in line with the CDC's high-impact strategies, and these are the areas that we've identified in the state of Georgia. Program deployment. Adaptability. We'll adapt all training to focus on the various age, gender, and racial demographics that present with the highest risk factors. So, HIV and aging, ready or not. The knowledge gained in the Science and Treatment College at UCLA will be incorporated in a series of ongoing training workshops for BTAN affiliate members and local providers of services to persons living with HIV and AIDS. And in terms of sustainability, we're going to work towards future programming. We will host an annual training to help support recruitment and membership. We'll have membership and healthcare workers as a part of this core group as well. This year, we're hosting bi-monthly lunch and learns that are focused on treatment as prevention and biomedical interventions, it should say. And we are also going to be looking at HIV and health literacy. And finally, our acknowledgements. We couldn't do this without this whole year, without the entire staff of the Black AIDS Institute, the entire staff and faculty of UCLA AIDS Institute, the staff of Sister Love, our sponsoring agency, all of the partners that were identified throughout this process, and each of the 2013 AAHU Fellows who made this journey a joy. So I want to thank you for this process.
Journey a joy.